In this next section, we want to discuss issues dealing with wound care that we felt like had not been adequately addressed by products designed for intraoral wound care or even external wound care for that matter. But we felt like we could design a product that dealt with these issues in a safe and effective manner. The first is infection, and bioburden is a term that's used more and more with wound care specialists when dealing with this type of issue. Critical colonization is defined as the presence of microbes to the extent that healing is adversely affected. And more research is showing that bioburden needs to be addressed as quickly as possible after injury, which also includes surgery. The problem is that most companies, in fact, almost all companies, develop products that are designed to either prevent or to treat infection, and they use chemicals that are biocides. And the problem is in the word itself, biocide. These chemicals tend to be indiscriminate killers. They're not designed to be like antibiotics that are specific to certain species of pathogens. These chemicals tend to kill all living cells. They're pretty good at killing the pathogens we want killed, but they're gangbusters at killing the cells of the immune system, which control the healing process, and that's the problem. For example, sodium hypochlorite, which is the active ingredient in Clorox bleach. Clorox bleach is 6.25% sodium hypochlorite. Let's look at the bottom bullet, 4%, which is about 60% strength of Clorox. 5 minutes of continuous contact required to kill Staph aureus, E. faecalis, and Candida albicans. But the problem is 0.025% is toxic to periodontal ligament cells. And we know that we use a much stronger concentration than that when we're dealing with doing endodontics. And we know that when we're irrigating root canals, that some of this is expressed through the apex into the periodontal ligament space. So we're doing damage to periodontal ligament cells with sodium hypochlorite. Chlorhexidine, 0.12% is the strength in Paradex and products like that are the most common oral antiseptic rinses. Pretty good against bacteria, not so good against fungus. But look at this, 0.0001% is toxic to periodontal ligament cells, 0.0005%, just 2 minutes causes complete alveolar cell death of osteoblastic alveolar cell death. And so, there's a lot of damage being done. It's a lot easier to kill the cells involved in wound healing with these chemicals than it is to kill the pathogens. And we felt like we could make a product, and we believe we did with SockIt, that can deal with bioburden and infection, but not to be so toxic to the cells involved in wound healing. Second thing is pain. Pain's very important in wound care. Number one, pain hurts, which is enough for most of us. But the second thing is most of us know pain slows the healing process down. This slide shows the proposed mechanism that most of us learned in college and in dental or medical school. And pain causes emotional stress. You have ACTH release, which leads to steroid production. And cortisol and other steroid hormones are immunosuppressants, so you suppress the immune system, which is in control of the healing process. Obviously, you delay wound healing. But a second, a second mechanism is vasoconstriction. A lot of people don't know that pain is a vasoconstrictor. This is from Thomas K. Hunt, you'll see at the bottom of the page, who is a guru in wound care research, so we need to listen when Thomas K. Hunt says something about wound care, we really need to pay attention. The second thing he says is special care should be taken to avoid vasoconstriction during the first day. Just a short period of time of vasoconstriction slows the healing process down. The problem historically with pain management is we've tended to underestimate and to undertreat pain. PCA, or patient-controlled analgesia, after surgery has come along in the last couple of decades, and that's been a big improvement. Now we can push the button, and every once in a while we'll get some morphine, and we're able to control pain after surgery better than we were before. But the problem still is you're dealing with a systemic narcotic. You can't just be indiscriminate with it. You have to have a time delay because of the toxicity. And also they've shown that systemic narcotics are not effective enough to deal with the vasoconstriction of pain. Just knowing that you're hurt but not caring so much about it isn't enough to deal with vasoconstriction. You need to get pain relief at the site of the wound. Studies have been performed with topical anesthetics and narcotics after tooth extraction. Bupivacaine, morphine, both were ineffective. Now, benzocaine showed some efficacy, but all of these have some cytotoxicity and systemic toxicities, even benzocaine. When you pick up a box that contains a benzocaine product at the grocery store or the pharmacy, OTC, you read that it says don't use more than 4 times a day unless otherwise instructed by a healthcare professional. There's a reason for that, because there's toxicity to benzocaine, and benzocaine specifically can cause methemoglobinemia, and you can go to the literature and see all kinds of cases of that, even with intraoral use where there was a large surface area being treated indiscriminately by patients. So even though benzocaine is safe, it's not totally safe, and we can't have a cavalier attitude about that, and we wanted to make a product that gave pain relief without toxicity, because that's important. Which leads us to foods and wound management. And remember that SockIt is 100% food ingredients. So let's look at a couple of studies. It surprises a lot of people to know that well-controlled studies have shown that foods and food-related natural products are equal to or better than current standard of care for many kinds of wounds. I'm just going to show you a couple of slides. Honey versus Silvadene. Silvadene is still the standard of care for burns. It's the prescription cream, that white cream. It's a real potent antibiotic. This study was done in, actually this is a combination of 2 studies in superficial burns. Honey was superior to Silvadene, the standard of care in controlling infection, healing time, scarring, pain relief, all of those. These were published 7 years apart. Honey was also tested versus Usol, which is like Dakin solution. Usol was developed in Scotland. It's a real potent and harsh product that they use to treat infected wounds that are draining and pussy. And they did a study in these wounds. Half of the group got Usol, half of the group were treated with honey. Look here, honey, quicker healing and shorter hospital stays with honey. Now, honey is now recommended to dress infected wounds in this institution. This was 2005. Infected wounds do not heal, so obviously quicker healing shows that the honey was better at dealing with the infection. Okay, that leads us to mannins. Now we're going to talk about mannins because we have mannins in SockIt. But let's talk a second about macrophages. Macrophages are immune cells. They're the large phagocytes. They are also the single most important cell in wound healing. They are the Arturo Toscanini of the Wound Healing Symphony, and the dogma is they're necessary for wound healing. 1 or 2 authors aren't so sure about that, but all agree they're necessary for normal wound healing. So what's the deal about macrophages? Well, macrophages control wound healing. Mannins stimulate and enhance the activity of macrophages. And just look at the bottom bullet. The higher the concentration at the wound site of mannins, the increased wound healing and infection control because of the enhanced activity of macrophages caused by mannins. This is from Shepetkin in 2006, just showing that not only mannins but other plant sugars, plant polysaccharides like mannins, stimulate macrophage activity. It stimulates their proliferation and their reactive oxygen species production, which is one of the ways they kill bacteria, and then their cytokine production, which is the way they control wound healing. Also from Shepetkin, the same article, this just shows that macrophages were created to take in different kinds of sugars because they're stimulated by that. They can, on the left, you see the sugar is being phagocytized or just eaten by the cell, but also notice that all along the membrane of the macrophage there are these polysaccharide receptors that are designed to take in different sugars that come in contact with the macrophage. And you'll notice in the center MR there's mannin receptor. There are about 4 or 5 of these different types of receptors designed to take in mannins. But this slide just simply shows that macrophages were designed to take in different types of sugars because they're stimulated and activated by it. And it just shows that once these sugars are taken in, and we're talking specifically about mannan because we have mannan in SockIt, that it enhances the macrophage activity. But they're designed to take in these sugars because macrophages are stimulated by them. Okay, that finishes this segment.